so. So are you recording this session for
Yeah.
purposes? So it might be sent out to all the other sites.
Wow.
Yeah.
Say very smart
clever
thing.
thing. What is that?
You take the monitor.
Yes.
Okay. So this is first case which was randomized to the BBS by you on November 25th, 2014. And it was actually well done. And some other issues
Actually, it's actually well done. It's no problem.
Anyway, good. So I think this is not only a BBS measurement or BBS presentation, but also other line of this already. There is many things here. So I just want to explain what more in detail for this case. But this, yes, remember this case, I just do the image very quickly. So this case, there is a region, culprit region in the circumflex. You see a very tortuous circumflex, and then if you treat this circumflex first, in terms of the right coronary artery, also very tortuous, but it looks like no significant stenosis. That's like the right coronary. And this is how it looks like the LED, which we are discussing now. You put the BBS somewhere here. But this is very long LED, and angiographically it's very difficult to understand where the region is. So the first very important learning point of this case, like sometimes I splattered more than 70% can anything by angio. I mean, we have to advise everybody because we are by using the IVUS catheter marking, it's very important because co-registration between this angio and picture is quite challenging. So that's the most important message from this case. And so you analyze, finally you put the BBS there. Let's go to the picture.
It was very difficult to go out with the wire.
Yeah.
Bends in the CA.
So this wire into the LED, and then here, this is how it looks like the BBS scaffold here looks like, right? But before going to this picture, let's review the IVUS picture for this case. So put a intervention IVUS case. And the most important thing is co-registration to understand where we are. So let's start from the proxima. I recommend to compare the picture starting from the proxima because proxima site having more easy to understand in terms of the landmark. So big circumflex is here, and there is one diagonal branch and the second big diagonal branch. It looks like angiographically, just this to the diagonal branch, we see some stenosis, and there is clear stenosis. But septor, this is one more septor, and this is that, and this is septor. But very clear by angio. So let's start from the proxima. So from this case, so I'm going to the very proxima. And obviously this is left main. I didn't see the guiding catheter, but it's very clear this is left main. And this three, so this is the left main, and then this is very clear. When from the proxima into the left main, the first big side branch which we can see is of course always circumflex. So LED, this is obviously circumflex. And this is very typical picture. Of course, the of the time, the size of the vessel of the LED and circumflex bias is always quite similar. So, and then circumflex is very important to understand in terms of which branch is what. Because you remember the circumflex is for the lateral side. The diagonal branch is of course the lateral side. So to understand which circumflex direction is to understand which is diagonal branch. In general, the direction of circumflex is same with the diagonal branch. Okay, sorry. What did you?
No, that's interesting. I've never thought of it that way, but
You say the same side or the opposite side?
The circumflex and the diagonals are the same side of the image.
Yeah.
That's
most easy to understand which direction is what. So go to the left main, and then you see the circumflex. And this year, I just tell you, I was looking for the coronary from the proximal to the distal. So let's think about you are in the coronary artery, and then your circumflex is this side. Then looking from proximal to distal, pericardium side is this direction. So also very important, if you see the circumflex is right hand side, the pericardium is bottom. If you see the circumflex in the left hand side, pericardium is on the top. So pericardium and circumflex or lateral branch such as diagonal branch is 90 degrees. And so easy to understand. And once you understand which is circumflex and which is pericardial direction, opposite side is myocardium side. And septal perforator is going to the myocardium side. Then you can easily to understand and it's going to this direction is lateral branch is going to this direction is septal perforator. And you can understand which branch corresponding to which compared to ibis and angio.
good.
Yeah, this is circumflex. Let's go to more distal. So the circumflex more distally, and we should expect the diagonal branch here. So they are not exactly same direction, but I would say they are almost same direction. So this is the first diagonal branch, and then more. This is one branch. This is also the diagonal branch, and always same direction. And remember how it looks like the anatomy? We see this circumflex be moving here, and we see this branch, and now we see this branch. So if we adjust distal to this diagonal branch, such as here. So picture, this is just distal to the diagonal branch. We are in the LED and the ostium of this big diagonal branch. Recommending to evaluate the ostium of the side branch from the main branch because they are somehow estimated and also overestimated. It's on the angulation. But this kind of ostium, this is obvious. So even main ibis evaluation, we can recognize how it looks like the disease of the osteocyte branch. But this osteodiag is not so bad because of lunatic and this calcium, but that's little plaque burden. So it's very clear where we are here. So now moving more distally, then, this is how it looks like the myocardium by IVAS picture. Usually they are hypointensity, and whenever you move the picture, you see some kind of the band of the structure. So this is a typical part of the myocardium too. So this is you.
What is that? You said it's just a part of the myocardium.
This one?
Why does it look like that?
I just like myocardium is hypointensity. Okay, I will show more. But this is a myocardial bridge in the middle portion. So this is all myocardium. Why it looks like this, I don't know. But of the intensity is on the impedance based on the acoustic impedance. So if the acoustic impedance is high, looks like hyperintensity, such as calcium. Acoustic impedance is low, backscatter is low, and then looks like dark. So the intense impedance of the myocardium is lower than other structure of the coronary artery, then looks low intensity.
Okay.
Okay, move a little bit too much, but we are talking here. So
I just ask, couldn't it be pericular fat?
I think this myocardium. That's I think this is too close to the coronary artery. The reason I think this is myocardium is actually patient having a lot of myocardial bridge. I feel more distally like here. I just make the movie as regular picture. See, this is all myocardial bridge close to the coronary artery here. This is all myocardial bridge. You can see this is myocardial bridge. This is just I know. I saw some picture and then compared to sometimes with pathology, and this is how it looks like the myocardial bridge. So
it's a little intramural.
Yeah.
Intramural, and you have
Yes.
a bridging over it.
Yeah. So
But
yeah.
it's also all the part in the lower part of the picture.
But in opinion, I think this is all around is myocardium. But terminology, I say this is the myocardium site, this is pericardium site. Only function is making the bridge. This is already there because this is the myocardium site. If we clearly, strictly speaking, only the bridge is this portion. This is on the top of the coronary artery. But this structure, everything is muscle. That's what I'm trying to say. What is important in this case is I see everywhere is myocardial bridge here. This very continue to the middle, like stand here. All around, this is all bridge. This is bridge. This is bridge. And this is myocardium. This is bridge. And almost up to the diagram. Still, I see the bridge. The bridge. In this case, shrinking of the coronary artery is not so much. This is long myocardial bridge. And it's a little bit hard to recognize this case, to be honest, somewhere here. And it's here. I think it's very important to recognize the bridge there because I think the DBS inside of the bridge is very bad. Yeah, the point of this picture is just recognizing how it looks like the bridge.
Because that's something we have been discussing, that we know that we should not stent bridging stenosis with metal stents, but
yeah,
it could be a good stent to put in a bridging stenosis, if it's a real stenosis there as well, because it is after a while.
Yeah, that's no, but I think that has to be, yeah.
Has to be.
Yeah. This but at least it's very clear. In the bridge, already don't see the plaque. So actually, inside of the bridge, how to draw the lumen and EM is actually challenging. So let me try to draw the lumen and EM here. confusing because most of the time difficulty is how to draw the EM actually. So this EM for me is actually here.
Something
Sure.
with a bridge part of the vessel, you never see any plaque.
Yeah, correct.
In
Okay,
this case or in every case?
every case. Later, I can send a paper. This way. I draw the lumen and the EM inside the bridge.
Yes.
Yes.
Don't confuse because inside of the bridge you have low intensity outside. You may confuse the EM should be here. That's usually start thinking. That has to be like this. And yeah. Move on. So remember, I saw one branch here. This is the septa perfecta which we discussed. This one. So diagonal branch of the ibis. Now we're looking at this branch. This segment is bridge, right? So more distal because we have to go here. So more distal, bridge, but then there's no branch. Now after the bridge, distal to the bridge, we start seeing the calcified plaque. And this is more clear. This is myocardium site. And then here. Now I see the branch, which is myocardium site, and I expect this is septa perforator. So septa perforator of this one is, I believe, this one. This stuff, right? Should look into this diagonal branch soon. So, and then this stuff, not yet. It's very tiny septa perforator again. And then more this stuff, you see this is diagonal branch here. So this branch is now is this one. This small tiny septa here too. Here, which we hear by ibis. And we can see the calcium here, but it's very clear what's going on by angio. So here, this is, I see this diagonal branch, and the study, there is some disease, and again there is septa perforator, and then just to this septa perforator, looks like this is the most tightest part. Basically, now we are very clear. We see diagonal branch, and we see this tiny septa, and what we see here in the ibis picture is just distal to this tiny septa. So if you know which branch is what, you clearly understand this segment is corresponding to this small area. That's understand this is a region. Then how to put the stem here is very clear. But very understand this is very difficult to explain it by angio and ibis picture. So you said when you do the pullback, and you should make some marking that's put it on the angio. That's probably the most easiest way to see. Measurement. So I have many places which looks like very disease. So speaking, every looks like very disease. But as usually I say, it's to find out the maximum plaque burden is find out smallest lumen area. And this is because there is a big, it's a little bit hard to say what. But I think, again, just moving a little by little, and try to draw the lumen. So the same is like a little bit protruding. So is going to like this, and here is like this, and then here, and this is so funny shape, and I go like this. Probably I draw the lumen like this, and then I move a little by little. So this is how I'm okay. And then, so this portion is very easy. So let's go to the easiest portion here, and then here. And we discuss have to make imagination based on the back and forth movement. So I draw like this because it's smooth. I draw, I make one frame before after, and go to the frame which having something clear picture. This is not much. So if I come here, the EM border, it should be like this. So then go back to my place, and then probably I'm comfortable to do this. The number is 70%. I many frame, and everywhere looks like more than 70. So I think this looks okay to consider significant. But
have you used reference segment for the EM, the reference? It's very difficult to see because of the classification. It's very difficult to see what true lumen is.
Sure. Yeah. So if so, let's a bit more like here and draw the EM here, and this is very clear position and in the reference which is close to here, and the EM area is 7.8, and then go back to my original position and EM area 7.07. So the difference of this side to here, that I think I agree to do so.
Very good. That method is very helpful in this case, and the other one I randomized.
So this is the picture which we got from you on the PDF file, which generated on the software directory. So this is your measurement. And thought you may confuse this outside structure EM. It looks as though the EM is bigger than. Yeah, that's what I thought. So then actually we pick up the same segment. This is inside the structure, and then is going to be outside. EM has to be this red line.
Yes, I get a reference from the distal part of the vessel, and that it should be probably the same as U 7.8. To get the lines absolutely right. I just to have the reference in the right place.
I understand what you say, but you should care how this is too. My point is this structure. So I understand this portion is difficult, but if like this portion, you realize this way instead of this way.
Okay.
Yeah. Okay. And in terms of the lumen, there is here and the curtain is here. This is a little bit funny shape, and over this is going to be we pick up 70% as well. In this case, that's it. Meaning like this many so very hard to register. Basically, it can be done based on the structure, but easy during the pullback, you just record the capacitor which is sitting. Also, by IBAS picture, there is a huge muscle bridge here, and whether the standalone scaffold is not our question, but at least to recognize and then analyze inside of the muscle correctly, that is important. So the message from this case.
Get the reference vessel reference more distal,
Sure.
Half a centimeter distal, more.
Sure. Sure. But
Here. See when it's there.
Okay, so you direct to the, oops.
Okay, that's good.
This is interesting. Even this is
So you,
distant LED. This is already
this size 7.8, and put your spot.
this side, and then this spot is here.
Yeah.
Yeah.
You only have 6.5. So
Yeah.
7.8 here.
Don't 7.8. 7 is just reference for you to analyze how looks like the EM looks like. I recommend using this lumen of this and then calculate the plug burden. But at least you have to analyze this EM. And to here is possible because this is very clear EM border. This one, I agree, it is difficult, but usually the curve of the body is very smooth. So the curve from here to here is like this. Okay, I am going to this way. I'm not going to like this. I'm not going to like this because this very reaction shape. So very smooth curve which corresponding to the rest of the portion. That's number one. The second is once you finish whatever thing as the best, little by little, and not too far, but at least close to the place which you see more clearly of the EM, like this picture. This picture, I'm much more comfortable to draw the EM like this because of the portion is pretty much visible. Find how looks like the shape and looks like the number, and just go back your original interest portion. And similarly, that's the best to get the plug burden from this slice.
Okay.
The next one, which we just received recently, this is your second case to the BBS, and it was down on December 16th. And remember, this is LED, and it looks like the disease diagonal here, and so it's here, and diagonal is here. You put the BBS from here to here, measurement, and this is our measurement. And I think, especially this picture, we agree for measurement, but you are going to outside, that has to be slightly going to inside, and this is also has to be like this. Okay, let's open this case. Okay, this case, as what we did in the previous case, let's open the angio 2, sorry. The culprit is right coronary artery, and there is very tight stenosis in the right coronary artery, which is like this. You move to the left coronary, but the circumflex and LAD was separation, and very difficult to engage, and then you engage. This is how it looks like the circ and LED. And let's move to the better picture for the LED. Looks like this one. You may remember, almost double butted left domain. So this is LED. Circumference was not visualized in this picture. So from here to here is no branch at all. Diag and septal and second diag and here. So that's how it looks like the anatomy. Diverse picture. So this is in, and I'm sorry, this is outer. We don't see the guiding cluster, which was well disengaged. So we to the LED. So we see the bifurcation, which means the LED and circumflex is separated. And is already also the LED. We don't see circumflex. So this study, and in the LED, there's no branch in the proximal portion. And the first one, this one is the branch which we separate. The first diagonal branch is this one. And the second one, this is the first branch. And then this is the second branch. So this first, which is first, and the second branch, which is opposite with the diag, which is septal. And more, there is one more branch, which is the same direction of the first branch, which is the diag. Because we don't have the circ, we just have to use diag and septal as landmark. But this is very clear. We see this branch first, this branch, and then third. Where the most tightest is actually that is starting again proximally. Before the branch looks okay, and this is first branch, this is the so moving distantly, and this is okay. Septal has already gone, and septal is going out here. So it looks like just distal to the second branch such as septal, but before let's clearly show the key point. The disease is actually here. Distal past septal and proximal to the second diag. It's here. So the picture which we see, actually this is very dark. And if you see such a dark picture, one possibility which you can change is changing the so I'm going to change the picture to be bright and bright, and the contrast needs to be a bit sharp or a little bit more like this. I mean, recommending changing too much for the brightness. Most of the time, issue of the darkness is air bubble, cassette itself. But if you see this picture, probably this is much easier to understand compared to previous. So we change on the console directory after the pullback. So this, for me, it's very clear. Looks like somewhere here is the smallest area. And this is probably not super difficult to go like this. So is function is very clear, and this is okay. And function is actually which I will discuss more. This is and for me it's here. So I go to the end, it's going to like this. And it's almost impossible, so I just go to something smooth shape and try to check back and forth, something like this. This is what I want to draw. Then I move to the back and forth and to find a better shape of this portion. So let's move to, there is no place which I can see. Yeah, like here. I see one frame. Yeah. Frame, it's there. So mind this shape, and then this portion I keep mind like this. I keep like this, then bring to my place, and then I just keep the shape which I see like this style. Finally, I could get the plug burden. It's 71%. So this is like I get. You are there. This is I mean this is almost okay, but this portion which is here, I think that true EM border is a little bit more inside, which is like this. But this is difficult because everything looks dark. So suggestion is if you see such a very dark image, check brightness slightly, then recognition is much easier. So this is, and I just go back to the original, and you see how it looks like the original looks like. Picture is like this. So it looks easier to recognize, especially this portion. This one, this is after changing the brightness. Brightness is help you to understand where we are. Okay. Okay. I think this case is also, we agree. This is well done. Everything in place. After the stent, scaffold implantation, final area is big. I just want, yeah. Think about this case. The implantation. It's okay. I see the expansion well. I analyze the minimum Lund is actually good. This is like 7, so done. But I mean, this is minor, but very distal. I see some dissection. Probably you recognize like here. Probably nothing, but just mention there is some dissection distally, like here. Which is here. Okay.
Is it relevant?
No.
No.
Yeah.
Good.
That's question. Now I'm going to show you the clinical probably relevant some issue of the other case in terms of the edge dissection. Let's do this case. This is which I won't mention today for you. So this case, I think this may be clinical relevant section. So this is the number 8. Huh?
Something creates the. No, it was before I stented. Okay.
No, I don't think so.
Created it?
Yeah, I think so.
Kind of a dissection. Dissection.
Yeah, let's check this case together. Everything. Case number 8 and October 30. So the angio for this case now. This case, there was LED here. Just keep this picture just for the comparison purpose. So this is region. I'm talking here. So keep in mind how it looks like the size of the proximal portion. Now, you take the picture further, and then you put the is the IVUS catheter, and then this is the balloon, this is stent, sorry. And everything, this is how to expect the final.
Mm.
Yeah. Okay. I think the stent was implanted from here to here. Let's is stent, right? And you see here, this is how it looks like. I put the picture here. Keep in mind proximal portion of the LED. This is the put it. Keep in mind how it looks like here. Typically, comes this portion. You see, the diameter is smaller.
Yeah. Okay.
Try to explain by others. I mean, I'm not talking about how you should do, but talking the recognition is important because you can explain everything for this case. Let's yeah. Okay, sorry, this is where we are output one. I think I put here. Okay, this is the first picture after stenting. So the stent segment, which is well expanded. Looking, let's show the picture at movie. This is the stent, well expanded. Now reaching to the proximal edge of the stent. Okay. To recognize is the portion. This.
Can you before the stenting?
Okay. I think I should have. Let's see. Let me see. Wait a second. Sorry. Wait a second. I'm talking to the perspective and output one. Yep. This is the put it. I should not show the mirrors. Sorry, I still open here. Okay, sorry. We don't picture without mirror for this case yet. Let me show different way.
Jag har inte varit kritisk mot läget så gör jag använder pullback. Det innebär att vi kan inte göra ordentliga tolkningar av våra ämnesfilm. Så vi bara drar med olika hastigheter. Så tror man att man gör det så. Men med här analysbeväsen så får man alltid en pullback. Det går inte att undvika. Frågan är om man inte ska skrota den andra ögonen som bara kör in. Så får vi alltså med kostnaden är om vi ska köpa en plus en pullback device. Så är det säkert inte något större skillnad. Det finns ingen pullback på landet.
Men du kan dra in den också. Om du låser ner.
Ja, det kan vara en fördel att du går ut och kollar någon gång. Men att du får ett sådant du ska tolka det. Du kan inte tolka dem som vi gör. Jag är sådana handlar.
Nej, nästan ingen annan.
Det finns ju.
Vi brukar ha dem hemma. Man kan ta fram. Men det är sällan.
Ingen som gör.
Nej.
Ingen som gör. Här är man liksom. Här blir det så. Så får man ner också.
Okay. I think so. Looks like the pure region. This is nice proclupture. Looks like the culprit region. nice plaque rupture. So go to the proximal.
Nice
And
structure.
yeah, nice plaque rupture here. This is really nice. Yes. Go to the proximal. This is how we are on the proximal side. And this is the circumflex, by the way. So keep your just distance to the circ. This is how it looks like. Yeah. I think when the post picture is out near, so let's try. That's probably you can see the side by side. So project 2, scale 1. Sorry, anyway, so keep in mind how it looks like
Here, stop here. Go back a little bit. Here, stop. Here. Yeah, forward. A little bit forward.
The other way.
The other way. Back. Here's the lunar plaque here. It's a little bit. It looks a little bit like the thrombosis you mentioned.
This one?
Current.
Portion. Okay. Okay. So let's keep this one. Okay. So let me open the one which we discussed. That is a post. So let me. Okay. The post of the stenting, which should be quicker to open. I don't think this is a hematoma. This is like that sometimes we see like layer of the plaque outside of the structure. We don't know what it is. It's probably inflammation or something. But post much more obvious. I will show. This is more proximal. See the hematoma is from here to here. And more proximally like this. More proximally like this. So this picture is also looks very good. Let's show the changing the brightness more.
It's a difference. I can see that.
Just compare how it looks like this. Obviously something additional, right? That said, this is okay to leave it alone, in my opinion. But first, the smallest lumen area is here. It's 7.1. I mean, when you have the hematoma, you consider to put a stent or not. And what is important is several things. One, what is the smallest area? And now it's 7.1, which is big. Second, you cover the site or not. And this was already probably covered in tent. That is I prefer to explain to you. This is a case which we had at the Columbia, the region, and post-balloon. It was okay, but the distal post looks like more stenotic. That's had by IBUS. This is a picture of the case. So in the middle, there is a huge hematoma and pushing to the lumen. And then proximal side, this is section, and this is a longitudinal picture. So look like this medial dissection happened, longitudinally, the site is here, and then expand this study. If a cartoon is what will happen, this is the original region, and dissection happened in portion, and that is longitudinally. And blood starting entry site, but no the entry site, and then blood accumulating inside, and that's causing the hematoma, and pushing to the lumen, and then looks like small. And this is very typical picture by IBUS. You see that, and usually the hematoma is like helmet shape and homogeneous. Top of the normal segment, like this picture. Your picture is somehow similar. This is like hematoma on the top plaque, and then pushing to the lumen. But carefully, I think it's the end of the hematoma, meaning the entry site is segment. So for me, I check very carefully, but I couldn't see the here. Yeah, but still I'm not very clear. Usually the entry site we see like backhand flow, weekend flow, but I don't see here, and it looks like all the hematoma. My interpretation of this picture is this segment entry site was already covered by stent. So that's what I saw in this picture. Like this is not, and then continuously blood is inside and then making bigger and bigger. Yours looks like this was already covered, and so the direction of the dissection is starting distally to the proximal. If retrograde into the blood flow, hematoma is less likely to going to bigger. But if the dissection slice is antegrade and entry site is still open, hematoma is going to be bigger and bigger. So, okay, three things. One, minimum lumen area is 7.1. It's okay. Second, and I guess entry site was already covered by stent, and the degree of the hematoma is red instead of antegrade. So including together, I guess how hematoma is getting worse or is healing. So, I thought even I see the hematoma, which is leave it alone. Okay. Again, the important message from this case, you have to recognize. And geographically, it is very clear. This worse than before. It's very clear, explaining what's happened. This is hematoma. And altogether, you should do in addition, that's a choice. The concern for this case is this kind of phenomena at Columbia. We usually wait like 5 minutes and just do again IDAS, and we see it's getting worse or getting stable, and we consider what we should stop. That's the message from this case.
Yeah. Kind of squeeze the thrombus backwards in a closed compartment. That's what you think.
Yeah.
Yeah, that's good. I would keep the patient alive, but I think so. I would otherwise.
Okay, I think that's it. What I would explain to. It's a learning point of the cases from your side.
Akiko. Thank you very much.
Okay.
Thank you.
Okay.